Hello everyone, welcome to a high-yield session on inflammation. In this session, we are going to discuss some of the very high-yield points from which most of the questions are asked for your postgraduate entrance exams. And these are extremely high-yield concepts which are not mentioned in Robbins or the normal textbooks you read. Fine, but of course, these are going to create a difference in the postgraduate entrance exam, especially your INI CET or the upcoming next exam or whatever it may be. Fine? Yes. So I'm going to just discuss. I'm not going to go back and start the chapter from the first or from the beginning. I'm going to just focus on the salient high yield points that you should focus on. Usually, we know that in acute inflammation, there will be neutrophils, neutrophilia, increased neutrophils. Whereas in chronic inflammation, macrophages will be there. There are some exceptions to the cells in inflammation. Number one is in acute typhoid fever, you will have neutropenia. In chronic pseudomonas, chronic pseudomonas, again you will have neutrophilia. Okay, so please focus on these 2 points. They are potential MCQ questions. Then, what are the hallmark of acute inflammation? The hallmark of acute inflammation is increased vascular permeability. Remember, this increased vascular permeability is maximally seen over venules. It is a potential MCQ question. Okay, now let us see the various mechanism of increased vascular permeability. Number one, we have endothelial cell contraction. Then we have mild endothelial injury, direct endothelial injury, okay, and leukocyte mediated endothelial injury and neovascularization. Each of these mechanism will occur in certain areas of the microvasculature. For example, endothelial cell contraction occurs in venule. It is an immediate transient response. It is immediate and at the same time it is transient. That means it will last only for a few minutes. Remember, this immediate transient mechanism of endothelial cell contraction is the most common mechanism for increased vascular permeability, and there it is because of a very important a mediator, that is what we call it as histamine. Examples, of course, important: mild thermal injury. The examiner will ask you, mild thermal injury will produce increased vascular permeability through which of the following mechanism? Second, in case of sunburns, there will be contractions. Burns means it will cause contractions. So remember like that. It is a mild endothelial injury. It occurs also in the venules and capillaries, but it is delayed and at the same time prolonged. Why delayed? It will happen only some 4 to 6 hours after the onset of inflammation, and it is prolonged. That is, it will last for some 24 hours to days. And the pathogenesis, the mediators are interleukin 1 and TNF alpha. Whereas direct endothelial injury is arterioles, venules and capillary. It is immediate prolonged or delayed prolonged. Mostly it is immediate prolonged, that is from hours to days. Cell necrosis and detachment occurs, and it occurs in case of moderate to severe burns or in radiation injury, bacterial infection. This question has been asked in JIPMER. Radiation injury, okay, has produced which type of, or it causes increased vascular permeability through which type of mechanism? It is direct endothelial cell injury. Fine? Yes. Leukocyte mediated endothelial injury, remember only one point, it is also delayed prolonged. What is immediate transient? The most common mechanism, endothelial cell contraction. And please focus on this mild thermal injury, sunburns, okay? Yes. And neovascularization, it can occur at any levels, any type of response may be there, okay? Angiogenesis, and it occurs, we have already discussed, that is neovascularization occurs mainly during healing, and of course in tumors also we will say there is angiogenesis, okay? Yes. Then, as per a 10th edition of Robbins, see, earlier in the 9th edition, it was mentioned that 2 terms, like endothelial cell retraction and contraction. But as of the 10th edition of Robbins, both endothelial cell retraction and contraction remains the same. That is the most common mechanism, that is immediate transient response. Then we have different group of selectins. Selectins, that comes in rolling adhesion, that is the recruitment of leukocyte. That process, there only we have endothelial selectin, leukocyte selectin and platelet selectin. What is the CD marker here? CD marker is nothing else but CD62. Remember, these selectins are activated again by TNF and interleukin 1. Okay, all these are straight one-liners. Then we have integrins, and we have two types of integrins, children. One is beta 1 and another one is beta 2. Beta 1, what is the name of the molecule? It is alpha 4 B7. The CD marker is important, CD49 and CD25. Yes, this CD49 and CD25, this has been one time asked in AIMS. Okay, CD40, which of the following are markers of integrins? Markers of integrins are, okay, the CD49, I am writing here. Then another one is CD25, I am writing here. Then CD11 and another one is CD18. So these are the markers of integrins. Markers of integrins. So beta 1 is mainly the ligand is VCAM, and beta 2 the ligand is ICAM, and the beta 2, no, remember the CD marker. If you don't remember that LFA, MAC1, if you don't remember that also, no problem. The CD marker is important, CD11A or CD18, CD49, CD25, CD11 and CD18. So they are the markers. I am highlighting it again. They are the markers of integrins. Then we have two types of leukocyte adhesion deficiency. Okay, that is the problem in this adhesion process. Okay, yes. So that is due to either defect in selectins or integrins. So we have type 1. Type 1, remember children, type 1, the leukocyte deficiency. Okay, yeah, we have type 1, type 2 and type 3. In type 1, actually what is the problem? In type 1, the problem is CD11 and CD18. That is integrin. There won't be any integrin expression. Okay, and it is usually an autosomal recessive inheritance, and the patient will have, okay, what is the important clinical feature? There is a delayed umbilical stump separation. Okay, and the baby may have gingivostomatitis and skin infection. So all these are very classical features of leukocyte adhesion deficiency type 1. Remember, type 1 means it is integrin. Okay, integrin deficiency. Integrin deficiency is in type 1. See, so all these are these defects, no, leukocyte adhesion deficiency type 1, we have type 2 and type 3. They are all togetherly we call it as defects in neutrophil migration. Okay, defects in neutrophil migration. So let us see what happens in leukocyte adhesion deficiency type 2. Type 2 is again autosomal recessive. There is a defect in sialyl Lewis X. Okay, or I can say there is defect in selectins. There is defect in selectins. Integrins, what is it? LAD type 1. LAD type 1 is in integrin deficiency, whereas selectins or sialyl Lewis X is absent, or whenever there is a defect in fucosyl transferase. Okay, all these are, okay, molecules name. Okay, yeah, fucosyl transferase, sialyl Lewis X, selectin, all these will cause a leukocyte adhesion deficiency type 2. Okay, and so when the selectins are inhibited, so which process is going to affect here? There will be inhibition of rolling. Inhibition of rolling. All these are MCQs. All these are MCQs. Inhibition of rolling. All these are MCQs. Autosomal recessive inheritance is an MCQ. Or then absence of sialyl Lewis X is again an MCQ. What is the clinical pictures? I told you, in LAD type 1, there will be gingivostomatitis, there will be recurrent skin infection, there will be delayed umbilical cord. That is a classical. Okay, they will give a history. In that, the one keyword you have to search for is delayed umbilical cord separation and Bombay blood group. If it is delayed umbilical cord separation, you can straight away go, it is LAD type 1. If it is Bombay blood group with recurrent bacterial infection and mental retardation, you can go for LAD type 2, sialyl Lewis X absent, selectin deficiency, inhibition of rolling. Fine? Yes. We have third type, that is called leukocyte adhesion deficiency type 3. Okay, type 3 means actually there will be, it is actually a variant of type 1 only. In type 1, the integrins are totally absent, whereas in type 3, the integrins will be in the inactive state. Okay, so the integrins usually will be in inactive state. During the time of what is that recruitment of leukocyte, this inactive integrins has to be converted into active integrins. That process, that is whenever there is a failure in activation of this integrin, we have something what we call it as LAD type 3. Remember, it is also again a type of what LAD type 1 only, but this picture, no, it clearly differentiates. Okay, whenever there is a problem in rolling, it is LAD type 2. Whenever there is a problem in adhesion means that is integrin. No, integrins only helps in attachment. So LAD type 1, and whenever there is a problem in activation, it is LAD type 3. So this slide itself will give you good idea. Fine. Once that is over, let us see what are the ligands for integrins. I have told you, BCAM and ICAM, that I am going to discuss a bit detail. And remember the markers of integrin. BCAM and ICAM, it is usually in endothelium. And if glycoprotein 2B3A, whenever a problem in glycoprotein 2B3A, we have a condition called Glanzmann thrombocythemia. Yeah, so it is in platelets. Then fibronectin, vitronectin, collagen and laminin. So once it has been asked in AIMS, so which of the following are ligands for integrins? It is a multiple answer type question. In the option it was fibronectin, BCAM, okay, laminin was there, and glycoprotein 2B3A and glycoprotein 1B9 was there. Remember, glycoprotein 1B9 is not an integrin, whereas glycoprotein 2B3A, fibronectin, vitronectin, BCAM, ICAM, collagen, laminin, all these are the various ligands for integrins. Then for diapedesis, we have something called as PCAM, and what is the cell marker? CD31. CD62 is for selectin, CD31 is for PCAM. Then next we have what are the chemotactic agents. Yes, already I have discussed leukotriene B4, C5a and interleukin 8. Yes, this has been a question once in JIPMER. They have asked this in JIPMER. What is that? Interleukin 8. Interleukin 8 is also a chemotactic. Which of the following interleukins or cytokines are chemotactic agent? Answer is interleukin 8. Now, what are the receptors for the recognition of microbes? So, before the phagocytosis process, there is a process, there is a very important critical step called as that is the recognition of the microbes. So, microbes has to be properly recognized by the macrophages. So, we have some recognition receptor. Number one is what we call as Mannose receptors. Mannose receptors are nothing else but N-acetyl glucosamine and N-acetyl galactosamine and sialic acid receptors. Scavenger receptors, they are mainly for LDL receptors, and macrophage integrins. Integrins means remember two CD markers, CD11 and CD18. Just also straight away MCQ question, or they may give you like in INICET, they may give you match the following. Okay, match the following type of questions. Okay. Then opsonins. Opsonins means what? They are the proteins, am I right? They made the microbes more tastier. So it will enhance the process of phagocytosis. Yes, this is a previous year PGIMER question. Okay, they have asked this in PGIMER once in multiple answer type question. Which of the following are opsonin? Answer is C3b. FC fragment of, we have two fragments now, FC and FAB fragments of immunoglobulin. Out of that FC fragment, then plasma lectin, mannose binding lectin, C reactive protein and fibrinogen. I am not going to tell much more. You will read this in immunology and microbiology. Then we have oxygen dependent killing, that is respiratory burst. In respiratory burst, what is the name of the enzyme? It is called as NADPH oxidase, also called as FOX. It has been a question in PGI 2016. Respiratory burst is because of which of the following? In that option, NADPH oxidase was not there. In that, what was the option? They have given phagocyte NADPH oxidase, or FOX. FOX was the J. Okay, we have a disease in which this FOX gene is FOX enzyme will not be produced. That is called as chronic granulomatous disease. I will be discussing later. So FOX means phagocyte NADPH oxidase, that is responsible for the respiratory burst. What are the other enzymes involved in respiratory burst? Again, this has been a 2015 PGI question in which, it's a multiple answer type question. Which of the following enzymes, not only the NADPH oxidase, but the catalase, which is present in the peroxisome, superoxide dismutase and glutathione peroxidase. All these are the antioxidants, okay? Yeah. So these are the enzymes involved in respiratory burst. So all these are oxygen dependent killing. But we have something called as oxygen independent killing. The oxygen independent killing is because of the granules, okay? The different types of granules which are present within the neutrophils, okay? Yes. In that we have primary, secondary and tertiary granules. So they will give you all of the following are primary granules of neutrophils except. So you should remember this list, okay? This is a very important slide. See, primary granules, they are also called as acidophilic granules. Primary granules are also called as acidophilic granules, okay? That is, they are mainly myeloperoxidase, neutrophil elastase and proteinase 3. These are the highlighted green color, no? These three are the most important one. Then secondary, we have NGAL and lactoferrin and cathelicidin and lysozyme. All four are important. Cathelicidin has been asked, okay? Which of cathelicidin belongs to what type of granule? It has been asked as a question from the physiology, okay? Yeah, cathelicidin. And lactoferrin, NGAL, of course. Then we have tertiary. Tertiary, we have MMP, that is matrix metalloproteinases. Fine. So these three are the important things you have to remember. See, this is how the formation. Okay, this arrow indicate that is first the primary granules will be formed, then secondary, then tertiary. But degranulation, when the neutrophils undergo degranulation, the order will be in reverse. See, this is very, very important. So if they ask you which of the following undergo degranulation first, first means you can go for the answers. What? CR1, albumin, or in option MMP. Fine. After that, you can go for cathelicidin, lactoferrin. Finally, you should go for myeloperoxidase, neutrophil elastase, and proteinase 3. Please go through this slide once again. Then, what are the microbicidal granule content? We have defensins, cathelicidins, lysozyme, lactoferrin, major basic protein. So, defensins are arginine-rich granule proteins. Yes, this has been asked. Okay, this has been asked once. In NIMHANS. In NIMHANS, they have asked this question in defensins. Defensins are arginine-rich granule proteins. Then cathelicidins, this may be a potential, future question. That is, cathelicidins, they are nothing else but the microbicidal granule content. They mediate oxygen independent killing. They are vitamin, which vitamin? That is the vitamin D only upregulate. Okay, vitamin D mainly upregulates the expression of HCAP18. It is actually a cathelicidin mediated protein, HCAP18. Fine. So that is upregulated by vitamin D. Lactoferrin, as the name indicates, it is an iron binding protein. So once this is done, please focus on this. Okay, this may be a potential what question in future. Okay, potential question in future for your INI CET. Okay, then what are the defects in leukocyte function? We have number one called Chidiac-Higashi syndrome. Number one, Chidiac-Higashi syndrome. It is Chidiac-Higashi syndrome is autosomal recessive. Long arm of chromosome number 1q42. What is the problem here? Here there is a defect in phagolysosome formation. That is, the lysosomes will fail to fuse with the phagosomes. So what will be happening? There will be neutropenia, diminished chemotaxis, giant lysosomes. See, you can see neutropenia, and in neutrophils you can see giant granules. See, I'm highlighting the granules with the red color. This is the, what is this? Now what I am drawing now, this is the lobe. Okay, neutrophil lobe, and okay, I am drawing with violet color. This violet color now, they are the giant granules. Neutropenia, it's not neutrophilia, neutropenia occurs. They will give a case history. So and so boy comes with complaints of oculocutaneous albinism, photophobia. Oculocutaneous albinism is a characteristic feature. Then peripheral neuropathy. Okay, so do you, what will be the problem diagnosis? And on microscopy, you will see giant granules. What is it? Chidiac-Higashi syndrome, autosomal recessive. We can see giant neutrophil granules. Fine. Yes, there is decreased NK cell function, natural killer cell functions, and of course, another most important history is thrombocytopenia. Thrombocytopenia. There will be easy bruising. This will be also in the history. Okay, these will be also in the history. So please go through this point. So you can very easily diagnose it is the, see this picture, characteristic oculocutaneous albinism. That means around the eyes, no, also there will be albinism, oculocutaneous albinism. The second of the criteria, second of this defect in leukocyte function, that is what we call it as chronic granulomatous disease. Again, it is most commonly in 70% of the patient, it is X-linked. Okay, there will be FOX. I told you, phagocyte NADPH oxidase. Yes, that enzyme is defect. In X-linked form, there is a defect in GP91 FOX, whereas P47 and P67 FOX are affected in autosomal recessive form. It has been asked in PGI, what is the mode of inheritance in chronic granulomatous disease? If it is a multiple answer type question, you have to go for both autosomal recessive and X-linked form. If it is a single best answer correct question, you can go for X-linked form because in 70%. It is also called as Bridges-Good syndrome or Q syndrome. Okay, just for completion sake. You see, usually chronic granulomatous disease only will be asked. Okay, so what are the features? Okay, what are the clinical features of chronic granulomatous disease? See, in chronic granulomatous disease, the clinical manifestation, the catalase negative organisms will be killed, whereas catalase positive organisms. So, in the history, there will be recurrent attacks of catalase positive organisms. What are they? Staph aureus, Burkholderia cepaceae, Serratia marcescens, Chromobacterium vilaceum, Granulobacter, okay, beticensis. Okay, most commonly Staph aureus. They will give a history that the patient have recurrent infections by Staph aureus. Staph aureus is a catalase positive organism. You will learn in microbiology. So the catalase positive organism cannot be killed because the NADPH oxidase is defective, whereas the catalase negative organism will be killed. So there will be a recurrent attack of what? Staph aureus, as well as typical and atypical mycobacterial infections and aspergillosis. Okay, all those mainly it is catalase positive organism recurrent attack. Okay, and that will be the history. And it is X-linked recessive. And what is the technique? Okay, the technique is now called as, so how will you diagnose it? That is called as NBTT, nitro blue tetrasolium test, which is a semi-quantitative assay. We will see that it is a test to find out the phagocytic function of the polymorphonuclear leukocyte. In normal patients, it will be normal patients, that is we have phagocyte oxidase. So the test will be positive. Okay, the test will be positive in case of normal individuals, whereas in case of chronic granulomatous disease, since the enzyme is not present, what will happen? See, see, in normal patients there will be a blue black deposit. This nitro blue tetrasolium dye will reduce the enzymes and all within the neutrophils, and it will yield a blue black deposit, whereas in case of chronic granulomatous disease there won't be blue. So the first case is a CGD, whereas the second is normal. Okay, CGD, that will be remaining in red color only. It won't turn blue or black because in chronic granulomatous disease, phagocyte oxidase enzyme is defective. Remember, it is a semi-quantitative assay. Okay, and it will only say whether the FOX enzyme is present or not. It will not say how much is affected. For example, I told some patients the complete enzyme will be completely absent, whereas in some other cases the enzyme will be partially present, like 50% will be functioning normal. That and all cannot be graded by using NitroBlue tetrasodium test. It will just say whether that enzyme is present or not. Then what is the other important test? That is nothing else but what we call it as phago flow test. What is that called as? Phago flow test. It is actually a flow cytometry. This may be a potential MCQ. Okay, yes, phago flow test, and it is actually based on the oxidative burst of the granulocyte. Fine, yes. And the dye what we are using is called as dihydrorhodamine. This is also called as dihydrorhodamine test. Okay, flow cytometry. Then we can go for myeloperoxidase enzyme activity or cytochrome C reduction assay. These are other things. Okay, flow cytometry is the most specific. Fine. Okay, I have already discussed about the clinical manifestation. Next, let us see what about myeloperoxidase deficiency. Let us see what is myeloperoxidase deficiency. So, myeloperoxidase deficiency, again, it is autosomal recessive. There is decreased intracellular killing. Okay, all these are defecting leukocyte function, absence of myeloperoxidase enzyme in neutrophils. Okay, and there will be usually candida infection. I told no aspergillosis in CGD. Similarly, there is candida infection. Remember, here both catalase positive and negative organism will cause infections. Since myeloperoxidase in chronic granulomatous disease, myeloperoxidase is normal. That is why catalase positive organisms are also catalase negative organisms will be killed. Here, since the myeloperoxidase is also absent, both the catalase positive as well as negative organisms will cause recurrent infections. Okay, will cause recurrent infections. Fine, and most patients will be asymptomatic. Okay, and what you can see characteristically in smear. Okay, as you can observe here, they are vacuolized neutrophils. Okay, you can see giant granules in neutrophils in chronic granulomatous disease. Here you can see vacuolized neutrophils. Okay, remember candidal sepsis. Then we have NET. Okay, also called as netosis. What is neutrophil extracellular trap? They are an extracellular fibrillar network which has increased concentration of antimicrobial substance. So this will prevent the spread of microbes. And what will happen here? The nucleus of the neutrophils, it undergo apoptosis, and that process is what we call as netosis. That is neutrophil extracellular traposis. That is netosis. So netosis, and remember the most important amino acid which takes place here is arginine. Okay, arginine. Fine, and this neutrophil extracellular traps, this has been implicated in the pathogenesis of autoimmune disorders like SLE and rheumatoid arthritis. Okay, this is a 10th edition update. Okay, this is a Robbins 10th edition update. Fine, yes. See, you can see here, the nuclear membrane undergo disintegration, apoptosis of nucleus of neutrophils. Okay, and that is what we call as netosis. Okay, netosis. Okay, that is a clear-cut picture. Okay, in Robbins, there is a very beautiful picture of neutrophil extracellular trap. They will straight away give this picture. They will ask you what is this. Answer is neutrophil extracellular trap. Then, what is the most important amino acids? Yes, it is arginine. Then, what are the diseases where neutrophil extracellular trap is implicated? Answer is SLE and rheumatoid arthritis. What is it actually? It will prevent the spread of infection, and the nucleus of neutrophils undergo apoptosis. We call it as netosis. Fine? Yes. Then finally we have 1-2 recent updates. Okay, these updates actually from journals. Okay, from journals. Okay, we have these 2 updates. That is diabetes and chronic dialysis. In diabetes and chronic dialysis, there will be problem in adhesion and chemotaxis. Okay, just for completion sake. Yes. And finally, we have some 3 anti-inflammatory cytokines. Number one is TGF beta. Number 2 is interleukin 10. Number 3 is lipoxin. Lipoxin is a potential MCQ question. They will ask you which of the following arachidonic acid metabolism is anti-inflammatory. Remember, lipoxin is the one and only arachidonic acid metabolite which is anti-inflammatory. Rest and all are pro-inflammatory. Fine? Yes. So, thank you. So that finishes part 1. Okay, INICET high yield points of chapter inflammation. Okay, chapter inflammation. Let us see, that is the rest of things. So far we have covered about this, yeah, and the next session we will be discussing about the rest of things, that is the granuloma, different types of granuloma once again. Okay, what are the different types of giant cells, tissue repair, everything. We will be discussing the high yield points. Okay, thank you.